Welcome, everyone. We'll probably give it a few minutes as people are still joining the call.
We can go ahead and get started. What do you think, Coder?
Yes, absolutely. As people are joining, good afternoon, everyone. Welcome to the GED Healthcare Systems Roundtable. For those of you who may not know me, my name is Connor Sullivan. I'm part of the GEDC team, and lucky to help with the GED thought leadership events. It's good to see everyone, and we are excited to have you at what is our 14th National GEDC Roundtable event. Today's roundtable is focused on a topic which is near and dear to many folks on this call: transforming emergency departments for patients living with dementia and their care partners. As always, the goal of this group and the roundtable is to create a collaborative space where health system leaders and mission-aligned organizations can exchange best practices with each other, share innovation, share their ideas, and elevate care for older adults. Finally, gratitude to our funders, the West Health and the John A. Hartford Foundation, and partnering organizations without whose continued support this good work would not be possible. We're honored to have three distinguished panelists leading today's roundtable: Morgan Davin from the Alzheimer's Association, Dr. Nida Degasis from UCSF, and Dr. Amy Shaheen from UNC Health Alliance, as well as the GEDC team. We're also excited to welcome our newest member organizations, including Haney's Luminous Health, Northwestern Medicine, US Acute Care Solutions, and Vituity, who all share our mission of advancing geriatric care best practice nationally. If everyone could please, if you'd take a moment and just introduce yourself in the chat, your name, your organization, and your role. While you're doing that, a brief overview for today's roundtable. We'll begin the opening discussion from our three panelists. Morgan Davin will start us off by framing the Alzheimer's Association approach to building dementia-capable systems, including national priorities and scalable initiatives. Dr. Degasis will then highlight real-world interventions being implemented at UCSF to improve identification, care experience, and outcomes for this vulnerable population. And Dr. Shaheen will close our panel remarks by sharing UNC Health System-wide perspective on embedding dementia-responsive care at scale and how the ED can act as a catalyst for connection and continuity. Following the panelist presentations, as is usual, we'll shift into a facilitated discussion with our very own and very talented moderator, Dr. Bice. And lastly, we encourage you to please make the most of this hour by sharing in the Zoom chat. The roundtable is truly at its best when everyone is learning from each other and engaged together. So please, like, as the session progresses, please chat in your insights and questions. And towards the end, we'll have the opportunity to discuss that, discuss your questions. And with that, I'll hand off to Kevin, who can introduce our first speaker, Morgan Davin.
Thanks so much, Connor, and thanks everyone for joining. I know we've got a couple new folks here today. Thanks for chatting in. As a reminder, the Healthcare System Roundtable, as Connor just said, is designed to be as interactive as possible. So GEDC, the Geriatric Emergency Department Collaborative, also hosts webinars with sometimes up to 500 participants around the world on topics. But this is, exactly as it sounds, meant to be a roundtable. If we are all sitting at a virtual roundtable enjoying lunch, if that's the appropriate time of day for you, wherever you're located, and hearing some experts talk about what's happening, but also chiming in with your thoughts and your experience in your system. Each of our participants in the Healthcare System Roundtable are either healthcare systems or sometimes organizations that work across multiple healthcare systems that have said, making our emergency care better for older adults is a strategic priority of our system. It is clinically important, but it is also strategically important in order to meet the needs of a changing healthcare ecosystem and capacity crisis and so many things that we're dealing with. And so this is a forum for us to swap ideas, to say, hey, that's really interesting. I wonder how we could do that. That's cool. You're doing that at UCSF, for Northwell to chime in and say, gosh, how could we be doing that in Northwell, or how can we learn from each other? So really excited about today's conversation. Nobody on the line needs me to talk about why we would be talking about dementia and Alzheimer's disease in the emergency department, except for simply to say, as we all know, the numbers of individuals with dementia and Alzheimer's disease is going up dramatically, and our emergency care system track record in caring for these people is not what we would like it to be, and that the impact to the patients, the families, the care partners, and the healthcare systems that are taking care of these individuals is substantial. There is a lot of harm going in a lot of directions. And I would go so far as to say you can't think of yourself as a good emergency department taking care of older adults unless you think about managing cognitive impairment. And you can't think of yourself as a healthcare system getting out in front of what is truly a national capacity crisis unless you start thinking differently about how you're going to manage acute unscheduled needs of people with cognitive impairment, or you will find that your ability to have capacity to deal with all your other patients is being severely impaired. So with that intro from me, I'm going to turn it over to Morgan, a friend and colleague, the Vice President of Healthcare Strategy at the Alzheimer's Association, to help frame up our conversation a little bit. After that, Dr. Degasis is going to talk about the amazing work that, and I know, Nita, there's so much to be done, but you guys are doing amazing work at UCSF and making your actual ER better for older adults. And then Dr. Amy Shaheen is going to talk about thinking about how you incorporate better care for people with dementia into a healthcare system strategy from her role at the UNC Healthcare Alliance. Morgan, over to you, my friend.
Kevin, thank you so much. It's great to be with all of you today. And I'll share a little bit from the Alzheimer's Association. I just have a couple of slides that we'll share in a moment. But first of all, with Alzheimer's Association, many people think of us first perhaps in terms of services for people who are living with dementia and their caregivers, from psychosocial support groups, those kinds of education and support resources, which is an important part of what we do. And I'll touch a bit on how healthcare professionals can access some of that from us. But one thing that's been really important for the Alzheimer's Association over the past several years is to really more present and more involved directly with healthcare providers, health systems, clinics and practices, so that we can be more of a partner to you in delivering better care. So I came to the Alzheimer's Association almost 8 years ago to lead our healthcare initiative. I've been close to 30 years total in working with and for physicians and other healthcare leaders in my career, a lot of time at American Cancer Society, where I saw things like navigation really evolve in the oncology space. in the dementia space, we're really working where there are a lot of things that are emerging now in the Alzheimer's disease and dementia space that we really want to make sure that we're working closely with emergency medicine, physicians and experts, and others across really all the settings from primary care through end of life and everything in between. So first thing, I want to make sure that you know about resources from the Alzheimer's Association. And we're here to advise and help. We have health systems directors across the country really focused on this mission of healthcare partnerships to help increase equitable access to care, improve the quality of care so that it's evidence-based and person-centered, and ultimately to really help achieve better health outcomes, which may feel like a bit of an uphill when it comes to Alzheimer's and dementia, but there are resources that we can help with. Here's our team across the country of health systems directors. Many of them have worked with a number of hospitals and emergency departments to encourage and help with becoming accredited through the geriatric emergency department accreditation, either to start that or to level up in that accreditation, but also in many other ways, both within and adjacent to the emergency department, because we know it can't all be solved in the emergency department, right? So these health systems directors are connected with many other parts of hospitals and health systems to help connect some of those dots. And then my other slide for you is about the resources that we can provide that you can go to directly online. Now, I believe Connor will put into the chat what the current link is. The one that's on here for ALZPro, alz.org/ALZPro, is not active yet, but we'll share our healthcare professionals link with you. But I want you to know this is a bit of a sneak preview, if you will, that at the end of July at the Alzheimer's Association International Conference, AAIC, in Toronto, we will be rolling this out. It'll be, announced and launched in Toronto at our international conference, but it'll also go live, online with ALZPro. So ALZPro is our professional hub for dementia care. It'll be a centralized place for all kinds of healthcare professionals, including in emergency medicine. It will feature training and education resources, clinical practice guidelines, journal access, other tools that help with the workflow, things that you can use in your practice. And ultimately, we are working on building out across the care continuum for risk reduction, detection, diagnosis, treatment, and management, again, across multiple settings. One other thing I want to leave you with, just for this little bit of introduction to some of our resources, is that the Alzheimer's Association is actively working now on some new clinical practice guidelines. Some of those will be more relevant to you than others, but coming up in the next few months include clinical practice guidelines for the use of blood-based biomarkers in specialty settings, clinical practice guidelines on diagnosis and staging of Alzheimer's, and cognitive assessment, including in primary care clinical practice guideline as well. So all of these will be shared through ALZPro, but we'll also, of course, we always want to stay in very close communication with this collaborative and with you all, and appreciate the chance to give you a bit of a preview, but we're also there with you as these new resources come out to make sure that you know about them and that they're directly available to you. So we appreciate the chance in this national collaborative and in communities across the U.S. to partner with you all, and we want to make sure that you know that we're here as a partner with you to help improve dementia care.
Thank you so much, Morgan, and thank you to the work that you and your team have done for many, many years. A comment and a question before we transition over to Dr. Degasis. The comment is your team of healthcare system representatives. Am I using the right terminology? It was from the last slide.
Yeah, we call them health system directors, but they're representatives of the association.
Thank you.
Yeah,
health
sure.
system. I want to use your term. You do. Healthcare system directors is just outstanding and a wonderful resource. And if you are responsible for running, healthcare system processes in your healthcare system and you don't know who your Alzheimer's Association healthcare system director is, that's probably a take-home point from today's talk. They're a good person to talk to learn about like what's in your community. Like, oh my gosh, we've got somebody up on a bed tower who's got dementia for a long time, and we're trying to figure out how to get them the services they need to get home. This is somebody who can help you, not just for that one patient, but just to know the landscape, to know what's out there. I found them to be invaluable resources. So if you don't know who yours is, you have an opportunity to have more resources to become available to you. And my question is this: which of these resources, if any, are patient facing? Because the other scenario I think about is someone comes into the emergency department, we diagnose them with cognitive impairment. Rarely are we going to diagnose them with dementia in the ER. We'll talk about that in a second. Are there any resources that we should know about to help that patient, their family, so their daughters, whatever, like you're like, okay, there's no reason to come into the hospital, but we realize you're in for an adventure. Are there patient or family facing resources that we should know about to help connect these folks with support as they go on, as they leave our department?
Thank you for asking that, Kevin. Yes, and that's really important. We have really a lot of resources. We spent many years building those resources, and you can access those. So both when AllsPro launches, but also now with our healthcare professionals link, that also gives you a way into those patient and caregiver and family-facing resources. But a couple of them that I just want to call out, in addition to our 24/7 helpline, which is a great resource, by the way. Two additional resources include our community resource finder, which anyone can use online. You can use it. You can also just have that as a link for any of your patients and their family to find resources in the community, like the kinds that Kevin just mentioned. The community resource finder is embedded in our website. And a new one is My All's Journey, which is an app that's really designed especially for the caregiver throughout the journey, and including for newly diagnosed. And when I say newly diagnosed, this is a resource that can really be helpful for people just at that moment when, hey, there's some kind of cognitive concern or issue, either that they have recognized or that's been identified through some kind of clinical encounter. So early diagnosed or even cognitive concern, these are good resources directly for them.
Thank you so much. And Connor, we might reach back out to Morgan after this and get a little of those put together. And as we send out some materials after this, we'll send along those additional links. Thank you, Morgan. Thanks for being a part of this. I'm going to turn it over to Dr. Nita Degasis, a close colleague, awesome in so many ways. And one of the ways she's an ER doc in the daytime, and a mom and many other things. But one of the ways that she's awesome is she is the champion of creating a more dementia-capable emergency department at UCSF. And although I think, as she would tell you, I don't think it's mission accomplished. I'm not like sure she's like, great, we've solved all the problems for all of our individuals with dementia. She's taken many more practical steps than most of us have at trying to figure out how, in an environment that is almost frankly hostile to people with cognitive impairment, and yet where they frequently need to seek help, how you do better. And so, Nita, thanks for everything you're doing. Over to you.
Thank you so much for that super nice introduction. We are far from being the best and far from being done with trying to make our emergency department better for patients who have cognitive impairment, which is the term that we use more than dementia, quite honestly, because we believe very strongly, we're a partnership with our geriatrics team and our neurologists, and we don't diagnose dementia in our emergency department, but we do a lot of screenings to try to find out who is at risk for dementia, who has evidence of cognitive impairment, and we'll talk a little bit about those things as well. But the only mistake, Kevin, is I'm an ER doctor at night. During the daytime, I'm administrative. Okay, so what I kind of like to break, I'm like an ER-minded person. So first of all, I like to break things up into kind of bite-sized, tangible things. So I'm going to talk a little bit about how we are identifying these patients who are at risk for cognitive impairment, the actual care experience, for patients that includes lots of things, right? When we think about care experience, we think about, were we nice to the patient? Did they like it? Are our press gainies good? But the care experience starts the second a patient walks in the door through their discharge. And it's not just for them. It's actually the care experience for patients is not just on the patients, it's also with their caregivers. And so we'll talk a little bit about different parts of the care experience. So next slide, how we actually are identifying our patients who are at risk of cognitive impairment. Now, literally there's like lots of lectures on like which screening tool is the best. I'm not here to like push one screening instrument over the other. I'm just going to say what we do. And even that's constantly under discussion and we're looking into better tools. Obviously, we rule out delirium first because there's that big overlap between delirium and are they cognitively impaired because they're delirious or is it dementia? And so we use 3 different tools, our BCAM, NuDesk, and AWOL. What I will say that makes us a little bit more unique is not only do we use this AWOL tool, but we added an I, which is for an independent assessor. So if a caregiver is there, basically that extra question that we ask patients of their caregiver is like, do you feel like your family member has had worsening memory in the last year? That alone is like such important information. I will like just say like my own father tricks his neurologist. My dad has Parkinson's dementia. And he has tricked neurologists for like a decade because his MMSE score wasn't really bad for a while. I'm like, I'm telling you, my dad has Parkinson's. He has dementia. Like, I can tell you this as his caregiver, but he was able to like pass the test. And so he was undiagnosed for a very, very long time. So I think that there's a lot to be said for asking caregivers this single pointed question because it opens up the opportunity for family members and patients to have access to a whole host of resources that they might not have had access to otherwise. So just food for thought if you want to add like a simple question for your family members who are there at the emergency department. So after we've ruled out delirium, then we of course use our mini-cog, our slums, our MMSE, which is what I was talking about. And then if the caregiver is present, we've also added the AD8, which if I recall correctly, our AD8 is it's like an informant interview to differentiate aging and dementia. It's 8 questions, and it does go through memory, orientation, judgment, function types of questions, but it's, yes, a patient can complete it, but ideally it's done by the informant caregiver. So that's how we do our screenings. Again, not the most exciting or sexy, but like we do find this is a really good window into like what's going on and a really important opportunity in the emergency department to identify these patients. Next slide. So now I'm going to jump into this care experience for both for patients and for their loved ones. So as I said, right, the experience for patients and everyone is like the second they walk in the door. Does anyone know whose emergency department this beautiful emergency department is? It sure is not mine. This is not what mine looks like. I want to be very clear. But Dr. Tolia is on this call. I saw him as one of the folks. This is UCSD's beautiful geriatric emergency department. I bring this up because some of these things are actually implementable in any emergency department, and you don't need like $1 bajillion to build a new emergency department. Though if you are so fortunate to get funding or you're building a new emergency department, which is what we're undergoing, I'm going to talk about some design elements that are actually very critical for older adults, specifically those with cognitive impairment. So this is what I would call like the platinum model. It's like really beautiful. Look how it has these sound absorbing panels on the wall. It has like boom mics that like speakers that point directly to the patient so they can hear. It's like ridiculously beautiful. And I say what's good for older adults, good for those with dementia, good for everyone. So this is what I really like the platinum model. Next slide. You can see this platinum model also looks really great in their waiting room space. And what you can notice here is they're actually doing a lot of things that we can all do anywhere, right? There's minimization of clutter, visual clutter, like so moving all the non-essential items. Like I went through our waiting room just like the other day, and I was shocked to see just the number of junk items that like pile up. Either patients leave them, or there's magazines, and there's like flyers everywhere. Flyers outdated from like 6 months ago. And so just like removing some of that clutter can actually make it just a little more visually appearing. There's like quite a bit of emphasis here on like reducing noise, using contrasting tones whenever possible, comfortable seating, which we'll talk about in a second, and then making it look like natural, like bringing the outdoors to the indoor. I don't have windows in my emergency department. Even in the new hospital that we're building in 2030, much to my chagrin, and every time the new planners see my face, they're like, yes, we know you're going to ask for windows. And we've told you for the last 3 years, there are no windows in the basement. Like you will not get windows for patients. Still, you can bring the outdoor space to the inside world. Next slide. So that's the general design principles you just saw. All of those things are actually pretty doable in any emergency department. You don't, like I said, you don't need a lot of money to do those things. Next slide. So what we're doing is, so that's like the platinum models, but like, and the general principles, but you can actually do this, like I said, piecemeal. And so this is what we're doing. So I don't have a brand new space, but what I do have is a little bit of extra funding that was donated by a family member who was like, we need better physical space design for our like the patient had dementia and really wanted like better space design. And so how can we make it more comfortable? And so you can piecemeal it. So I bring up high back chairs because it's actually really easy to get these. They're very easy to order. They're pretty expensive. They can go somewhere between like $1,300 to $2,000 a chair. But I have tested out many of these, and we just ordered replacing all of our waiting room chairs to be high backed. It's better for patients to be able to stand up. They can actually like support their head and neck better. They can actually get better posture. And actually there was an article, I think back in, I don't know, it was like the late 90s, which I know is like outdated, but I still thought interesting to bring up is how like different chair designs do affect how older adults get out of a chair. And these might actually reduce the risk of fall because it's much easier to get out of. So I tried them all. The high back chairs are super comfortable. And I highly recommend if you're going to replace chairs, even if you can only replace like 5 of them, use the high back chairs. Next slide. Obviously, if you have more money, you can use a recliner. These are more expensive and they take up a lot of space. So we don't use these, but they are also very comfortable. Next slide. One thing that I didn't realize until I like dove into how did UCSD make theirs so beautiful were these sound absorption types of paneling that can be used anywhere. They're actually made for auditoriums, and so they really do work. So again, noise is actually really, really very distracting, not just for older adults, but specifically for patients who become confused easily. So patients who have dementia who are in your hallways, right? It's like the worst possible place for a patient, and yet that's somehow where all older adults with dementia are placed, is like in the really busy hallway where there's like bright lights and it's like very disorienting. And now it's really loud and noisy. You can actually reduce hallway noise pretty significantly by installing these noise panels, and you can make them pretty so that, you know, bringing the outdoors in by making these more artistic really is another, I would say, like piecemeal way of making the physical space really pretty. Next slide. And then honestly, shockingly, nobody has enough bedside commodes. I have toured many emergency departments, also those who are level 1 GEDs, and I will tell you, there is a paucity of bedside commodes, shockingly. For an apartment of like 32 beds, 8 commodes, that's ridiculous. You know, you have more than like 8 older adults who need a bedside commode, right? Again, simple, super cheap. You can fold them and put them in a corner somewhere. So I bring this up because it's super cheap, easy, and no one's doing it. Like, we need to do better. Next slide. Things that we're specifically doing that others aren't doing, specifically related to dementias, we've actually included a lot of music back into our emergency department, in patient rooms, in patient care areas, and in the waiting room. So music as medicine is not like a novel idea, but in the emergency department, it's not really utilized that much because we're a very busy space, right? Like, and there's like, where are you going to put these people playing music? And like, if I'm listening to music, that's going to bother the person next to me. Or maybe it's the music that like actually makes me feel more agitated. So we have actually implemented, you know, personal device use in our ED rooms or in the hallway spaces with, you know, wipeable headsets, these really awesome Alzheimer's Association, or yeah, it's from the Alt store actually, this MP3 player that I see here that's already like preloaded with music to really use music as medicine. We have found that this has significantly decreased the rates of, I don't want to say agitation, but behavioral challenges in our emergency department, especially during procedures. So for example, placing a Foley when it's actually indicated, or an IV placement can be very uncomfortable. Like, how do we make those more comfortable for patients? Is we've been providing music. And so we've been providing music actually like from when the patient is like in their teens or 20s. So like, actually, if you think about it yourself, like what makes you feel nostalgic? For me, I'm like, oh my gosh, I listen to like alternative 90s on shift all the time. Like, that reduces my anxiety. And that's when I was a teenager. And so you ask them, like, you look at when they were born, and like you can very easily like Google, Spotify, Pandora search music from that decade. And it really, really helps, especially in patients who are decreased verbal. So they can't tell you necessarily what they like just look at the date that they were born and like go back and say like, okay, this is what they were in like when they were like 19, 20 years old. It helps a lot with the caregivers. It reduces the number of sitters that you need or coaches at bedside that you need, and they're super cheap. We are also experimenting with like music in the waiting room. That's a little bit harder because you can't personalize it as much. So we'll see how that works. But it's cheap and easy. You should do it. Other things that we do for our older adults, obviously, like activity carts. These are so, again, I'm like a pragmatist. Like, what can you do easily that you can buy yourself on Amazon that costs like super dirt cheap? All of these things right now that I'm talking about are like super dirt cheap, and like anyone, literally anyone can do them, and they can be available to anyone. And so we have tons of these types of activity things like fidget spinners, geometric shape stuff. Obviously like activity books, apron stackers. And then this might sound very obnoxious, but dolls. So there's actually like a lot of our patients really like having a teddy bear or a doll. It calms them a lot and provides some activity for them. And so at first I used to be like, I made a face because I was like, I feel like we're infantilizing older adults by giving them a doll. Like I feel really, I don't know, it made me uncomfortable until I saw how meaningful the impact was for certain patients who felt like actually giving a more like nurturing instinct and wanted to take care of something. And it really brought their calmness and brought their level of behavioral disruption down. Next slide. iPads are another cheap one, right? This again, very simple, like a lot of these are like tips and tricks that like these are not rocket science. Like you don't need anything like other than the iPad. It's pretty easy. We do more shows than games and music on them. We have found that a lot of our patients like different soap operas. And so we have found soap operas in their primary language that they really like. And that's really helped get them through the long wait in the emergency department or their long stay while they're waiting for labs and CTs and things like that. And so we found that that's been really very helpful also. Next slide. Moving on to something that's a little bit harder to implement, but I think very useful for older adults in emergency departments that we tend to do terrible things to, right? So Kevin said, like the ED is like a bad place for older adults, right? Things get worse in the emergency department for them. If you come in, you have an infection, their infection becomes worse, they become delirious, and then we strap them down in 4-point restraints and sedate them with IM drugs, right? Like that is what happens a lot, and that's terrible. So how can we actually avoid that final thing, the restraint use, the intramuscular use of sedatives and chemical restraints? So we actually took an outpatient model from the University of California in Davis from Kales, and we actually changed it to fit an emergency department. So we call it cold DICE. DICE stands for describe, investigate, create, and evaluate. And this entire protocol is specifically to avoid having what we would call a code 100 or a code 99 or whatever your emergency department might call it, by really trying to address areas of neuropsychiatric symptoms at the get-go. So what happens is a nurse will have some thought like, this patient seems to be pulling at their lines, they're pacing, they seem to be a little bit uncomfortable. It's like the nurse knows in like 20 minutes, this is going to be a complete disaster. So like, how do we avoid it now? So when they start recognizing some of these symptoms or these like neuropsychiatric symptoms, they overhead page. And then a multidisciplinary team like ascends to the patient's location, whether that's a hallway or like an actual room or a shared space. And we literally discuss the specifics of what is happening. Like, what do you actually see? Like, describe what you're seeing. Patients trying to get out of bed. They're yelling. They're pulling their nasal cannula. So you like literally describe it. And what this helps is it names the behavior. We're also used to saying like agitation. Agitation is like a free-for-all word. Like it doesn't help you know what the heck is happening, nor does it help you actually figure out why the patient is having those symptoms. So we really try to put your like, describe what the actual symptom is. Then we can actually look for like some underlying causes, right? So like, are they thirsty? Are they hungry? Is their bladder full? Like that is like one reason someone might be pacing that hasn't been addressed. So we think about what is the underlying trigger for that behavior and then create a treatment plan. And then We evaluate it, check back in after we've created this multidisciplinary approach treatment plan, and then we have been able to avoid using antipsychotics and using benzos and things like that. So this is something that we have implemented in our emergency department, and from our understanding so far, we're the only ones who have done it. We are working on publishing it at some point, hopefully soon, but it's been very, very successful. What makes this challenging, so it's successful, but it's taken years for it to, like, the uptick to take, right? So like culture change is hard, behavior change is hard, things in the emergency department are hard. And so just getting people out of the mentality of like reflexively sedating and restraining was challenging. And now people are like, we need to code dice. We are not going to restrain this 9-year-old. Like, this is unacceptable. And our restraint use has gone down, our sedation use has gone down, the number of like incidents against nursing and provider staff has also decreased, right? So less harm to our providers is also really good. So this is, I think, a really, really helpful. And then if all things fail, which nothing's perfect, this doesn't work 100% of the time, obviously, like that's just, we want people to be safe. You get hit in the face, like we can't just be like, okay, we're going to do, like, that's fine. That's not okay. We don't want someone to get punched. And so if somebody does require as a last resort some sort of pharmaceutical, we do have some more geriatric friendly medications that we use based on we have a full-time geriatric pharmacist. So that's been very, very helpful as well. So that's something I think that's really, really helpful. And then last but not least, next slide, I think what we haven't talked a lot about that actually really requires, I think, or should actually get some time is caregivers. I think we all know that caregivers are under a lot of stress, right? So I think on average, caregivers for patients with dementia work for free and more than 20 plus hours a week, right? That's a lot. 20 plus hours a week is like another part-time job. And so it can be very burdensome and it can be really challenging for caregivers. And those caregivers, they have their own increased rates of depression, insomnia, anxiety, like relationship and family strain. And of course, that then impacts the recipient of that care, right? So we know that caregiver burden is linked with increased emergency department visits, increased hospitalizations for the patient, and worsening disease progression, and which then leads to higher mortality, right? So that's bad. And then their cognition gets worse. So it like worsens their cognition, worsens emotional health, and just an overall poor quality of life. And so this is an opportunity for us to get in front of that, right? The caregiver is at bedside. How can we help the caregiver and thereby actually help the patient? And so we do a blanket first question, like, are you getting enough help at home? Just like a blanket, open-ended question. And then we follow that up. We use the Kingston Caregiver Stress Scale, which you see here. We don't actually like the Kingston. We think it's like too long, not particularly helpful. And so we're actually looking at other screeners. But I bring this up because I think it's just very important to not leave these folks out. Because while that might not be the reason that the patient is in the emergency department today, it could be the reason the patient returns in 72 hours or in 30 days. And there's a lot of resources that caregivers have not been able to tap into, right? Because maybe they don't know about the ALS Pro app or what the Alzheimer's Association can give them. Maybe they don't know that there is actually a local organization that's going to provide, like a daycare situation so that they can have some time themselves or even overnight care for some respite. And so there's a lot of opportunities, I think, for us to really start involving our caregivers better that we don't do very well across emergency departments. And I say this having been a caregiver for my father and being in emergency departments with him and knowing that my mom is super burdened and no one has ever asked her, not a single time. My mom looks like a different person. She's like not as healthy. She can't take care of herself as well because she's literally providing 24/7 care for someone who is wheelchair bound and has significant cognitive impairment, and no one has ever asked her if they could help her at home, which shocks me. It absolutely shocks me and makes me sad and makes me realize like we can do better and we should do better and we can all strive to do better. I think that's all I had in terms of slides.
That's awesome, Nita. Thank you so much. So many things to focus on there. I want to make one point to augment what it's implied in what you're saying and then turn it over to Dr. Shaheen. a really great system perspective. I'm sitting here looking at Andrew Pearsall, who, because you're happening on the screen I'm looking at, who's our new, at UNC, our new system of vice president of capacity creation, I think. If I have the wrong title, I apologize. But hired to like help us deal with our capacity crisis. And a capacity crisis is not unique to UNC, it's everywhere. And so the one piece of comment I'd add to this, everything you're talking about is so critically important, and also critically important for capacity creation. 3.4 days is the stat I'd add, which is you get delirium, your average length of stay is 3.4 days longer. So everything we're talking about here is obviously incredibly important at a human level. And implied in what you're saying, Nita, is you can't tackle capacity creation in a system if you allow a whole bunch of your patients that maybe some of them you can avoid admission in the first place. That's a slightly different talk. But if they get admitted because they get delirious, they're going to stay 3.4 days longer than if they didn't get delirious. And so all of this is not just nice to have. I would argue that it's a have to have. And no one wants everyone to come to the ER to manage their dementia. But folks with cognitive impairment will come to the ER, and we have got to be equipped to manage them better for their well-being, their care partners' well-being, and also for the capacity of our hospital to function. Otherwise, we will drown in patients who we're not really helping. We're kind of hurting, and we're impaired from helping other patients because we don't have the capacity to do it. So that's awesome. I'm sure I would love to come back with questions. I have one question to sneak in and then right over to Amy. Nita, if you could, do you have any visibility into like anything that's been particularly helpful for caregivers or care partners? So you guys ask these questions. Awesome. We don't at UNC. We should. You ask these questions. Any insight into like, my goodness, one service that's been really helpful or a theme that's come up is?
Well, first of all, I don't think our AFED would function without our full-time social worker. Like, wow, they're like, social workers are truly like angels in the emergency department. Like, they can solve everything and have access to all resources. So I would say social workers are very important. And then for us, what we refer, we actually have found like Caregiver Alliance and the Institute on Aging are really great resources that patients and their family members have never tapped into before and don't even know exist.
Awesome. Caregiver Alliance and Institute on Aging. Thank you so much. Dr. Shaheen is a close colleague at the UNC Health Alliance and also my dad's doctor, Dr. Shaheen. Thank you, Amy. We're all big fans of yours. And she's tackling sort of like, if I can put it this way, pitching to UNC Healthcare System, like, gosh, we really need to manage our individuals with cognitive impairment and dementia better across our system in order to meet system deliverables and take better care of our population. So I'd love for some of your thoughts on how what we're talking about today, or even more broadly, is a part of a system strategy from your perspective as you put this together for UNC Healthcare across our many hospitals. Over to you, Amy.
Okay. Can y'all hear me okay?
Yep.
Great. Okay. So I did leave the forward together on there because that's the name of our strategic plan. And this, I think it's really important for anyone thinking about interventions to align with your system strategy. Our system strategy, as Andrew's presence points out, is really getting patients through the hospital. We're a tertiary medical center, but saying no to some of the most critically ill patients across the state because we don't have capacity. And so when we had conversations about a year ago with our strategy partners, it really came out that our primary care offices didn't feel equipped to manage patients who have dementia in the normal course of their day. And so we wanted to figure out what is it. So we looked around the country for best practices and even applied to GUIDE, which was a Medicare program. Fortunately, I say fortunately because I think that there have been a lot of issues with GUIDE. We didn't participate, and I'm glad because it's allowed us to think about our own solutions to our own issues, which I'll get into in a little next slide. Why don't we look at that? So this is a typical patient, and I think many of you will see this in your families or in patients that you care for. This is Mrs. D. She was a retired school teacher with incontinence, anxiety, requiring help with her ADLs. She had multiple ED visits and a hospitalization, and she kept showing up in the emergency room, and it kept getting worse. As Kevin alluded to, you'd had multiple days in the emergency department because we don't have beds. We're waiting. We actually have between 3 and 14 patients every day waiting in our emergency department for skilled nursing facility placement because the families are overwhelmed. Patients in the emergency room develop delirium. They also, because of anxiety or falling out of bed, develop hospital-related complications. And we have very long stays. And really, it's poor care. The patients don't do better. It's not like they go back to their previous level of function. We know that a patient who has dementia and is admitted will never regain their prior function. And that was the case for Mrs. D. So it was a series of 5 hospitalizations over a year before she eventually died. Next slide. So we wanted to know, how big is the problem in our system? We've created a registry for dementia patients in our EPIC at UNC. We know that just within our triangle area, that's Durham, Raleigh, Chapel Hill, from end to end, that's probably 30 miles. We have over 10,000 patients living with dementia. Our academic medical home was the place that we wanted to target first. And we know that we have a tremendous number of emergency department visits. This is just 12 months. We had 2,097 ED visits and 941 patients admitted who had dementia. And these are from our surrounding counties. And so you can see that Orange and Chatham County, that doesn't mean much to you. We have a lot of counties in North Carolina. We have 100 of them. They're not that big, but we do know where these patients are coming from and that we're servicing them. And there are some really frequent flyers. 1,129 of those patients had more than one ED encounter. So we know that these patients spend a lot of time in the hospital. The average length of stay is 8 days. I mean, you get out of a cabbage faster than you do having dementia with a medical problem get admitted. And that we know that over 33 patients who have mild cognitive impairment or dementia are in our hospital every single day. And that requires sitters, that requires a lot of care for those patients, not to mention the impact on the families, being exhausted, having another elderly person sleep next to them and then fall. And then, it's just, I'm sure you've all had those experiences. And so then we were able to identify the practices with the highest number of patients. Next slide. So we just wanted to know, what could we do better? And again, we've been all over the literature. We have consulted with no less than 10 different institutions who've put some form of dementia care into their systems, and ultimately realized that proactive dementia care would be a better way to manage this, especially knowing that caregivers need that support that you all have alluded to. Trying to figure out what resources they have and what types of planning would help avoid hospitals and emergency rooms, and then trying to manage those patients even with urgent care and hospital at home options, and then eventually transitioning to palliative care and hospice. So these comprehensive dementia care management programs have been proven to reduce ED, hospitalization, and length of stay, decrease caregiver burden, and alleviate distress symptoms for people with dementia because they're in their homes and not in a noisy, scary place where people are sticking them. Next slide. So the Memory Connect model is what we've put forth. It's getting put into our strategic plan as I speak, and it's been proven to be a financially sustainable virtual model of care. So most of this can be done virtually with patients. We start, and I've just outlined, what our topics of discussion are. They're not necessarily going to be in this order. We've developed something called Compass Rose. It's a care management tool in EPIC, where each of these topics will be discussed with the caregivers, not necessarily with the patients, because they no longer have decision-making capacity. So how do you manage behaviors like escaping or not taking pills or not eating? How do you assess their cognition and their decision-making capacity? How do you make sure that patients don't fall at home, from bed alarms to, caregiver support for that? So, and then the other thing we've done is we've partnered with a third party who can do urgent care visits at home, so that if the patient doesn't ever hit the ED, they can do IV fluids, antibiotics, and then we're hoping to eventually make a handoff if that patient does need a higher level of care to hospital at home. Right now, this is all fantasy, but this is our plan, and you're seeing our strategic plan firsthand. So we think this will help our patients, their caregivers, the PCPs who are feeling overwhelmed, as well as the other patients, because our care managers currently, who are not as experienced in dementia, spend a disproportionate amount of time with these patients without actually the training to manage those patients. So healthcare systems that have implemented this have reduced ED visits as well as length of stay. So 25% reduction in in length of stay, and a 19% reduction in ED utilization in the worst performing programs. Some programs that offer a lot of in-home options have reduced their ED and inpatient use by 50%. So we modeled for the worst case scenario. We're hoping for the best. So my motto. Next slide. So that's all I have, and we'll let you know how it goes. Hopefully we can come back one year and talk to you all about it.
That's awesome, Amy. Thank you so much, and really appreciate the system perspective. I believe Jane Carmody, is a friend of mine from Johnny Hartford Foundation, chatted in about the data that you have, and really thinking, when you think about a system, you've got to be thinking about where are the patients coming from, where are the resources you connect them with. Any thoughts on, so I, as an ER doc, am thrilled. If you can cut down on 50% the number of people, we will never be the best place for people to get care that have dementia. Like, the ER will do the best we can. We'll do all the stuff Nid is talking about, and we'll still not be the best place. And if they can avoid an ER visit, fantastic. If they have to have one, any thoughts, in your talking with organizations on how the ER can reconnect back to these PCPs most effectively? Like, they show up, and what you don't want is for me to just do whatever I think is right. What you do want is for me to connect back with their network of care and try and make sure that whatever we provide is in agreement with that, congruent with that, and get them back to that care as soon as possible. Any comments on how to connect those dots if they do show up in the ER?
Yeah, so I think any of you who are thinking of these types of programs should think about building an EPIC registry. So our hope is that we'll be able to identify patients in real time who are in the ED, and then do outreach. We have an expert named Laura Hansen. She does this in the hospital. So she connects patients to care managers who are experiencing dementia while they're in the hospital. We're hoping to do the same thing in the emergency department, so that when we send them back to the PCP, they go, what am I going to do with them? Right? Like, I don't know if any of you have ever felt that way. I'm primary care doctor, so sometimes I felt that way. And instead, what we'll do is send that patient out with a partnership model. So you're going to go back to your PCP, but you're also going to meet with an APP who's an expert in dementia and be enrolled in our care management program. So that's our hope, Kevin, is that we kind of do this dual, like, ED prevention. So identifying the high utilizers, get them enrolled. And then when they're in the ED, when it's a kind of a crisis, we feel like that might be a time when patients would be more motivated, inclined, disposed to participate in these models.
Awesome. Thank you for that. And I see chats coming in of envy, even of your fantasies, Amy, and echoing how influential they could be. What a wonderful conversation. I want to open it up for other questions or comments. And while they come in, just reiterate that, like, from my perspective, this is about doing a better job by patients, but also about managing healthcare systems in today's era. Like, I really do not think you can successfully talk about capacity without thinking about how to do a better job for individuals with dementia, so that they can escape the hospital and ER whenever possible and as quick term as possible, and that those resources can be open for other people as well. We just won't tackle it successfully. The rate of dementia and cognitive impairment is not going to go down. It's going to go up, and we've got to get responsive on this front. Questions or comments from anyone here? We only have about 5 minutes left, but what an amazing panel. I want to open it up for any questions from others. Courtney. from West Health. West Health and Johnny Hartford make all of this work possible. Courtney helps run the geriatric ER team at West Health. Courtney.
Thank you, Kevin. So also thank you so much for everyone on the call, Morgan, Nida, and Amy. I think my question is more so, it's more so about the actual implementation of training for ED staff. And I was just curious to see, specifically for the folks who work in the ED, like what sort of barriers have you been, I guess, seeing in terms of like training ED staff in terms of like how to like treat these patients, but also how to like screen for them as well.
Then I bet you that goes mostly.
I mean, I laugh because I'm like, yeah, that's why it's taken so many years, right? So like time, no one has time for trainings. You have to pay people for their time, right? So like faculty, like they're forced to get whatever training I tell them to do. Like they have to do what I say, but nurses don't, and we have to pay nurses for their time, right? So like that can be a time that could be, and there's like competing interests, right? So they're like, this is something like we do this training course, like, okay, you want this, but then like, what are you going to give up? Right? Because I also want to be like, I want to teach you on front end workflows and capacity throughput and like throughput and operations, like all these other competing non-AFID things that we have to train people up. And so I think that's the biggest barrier. What we have done to like fix that is to show people how this will help them in their daily lives. Yes, it's good for patients. Everyone agrees things for patient care are very important. But when you can also show them it's not just good for patients, it's going to make your life better too, because you will spend less time at the bedside. You will not have to physically restrain folks. That doesn't feel good. You will have a better you will have a better shift. And like when people see that and it works, then it's like, then people are like, oh yeah, I'm sold. But I think that's like that's why it takes time, because you have to prove that it works.
That's awesome. And then if I can supplement with one comment, one additional way to deal with training is to, as much as possible, begin to hardwire these processes into the EHR so that it's not like someone thinking about, oh, I should do this too. And it's not as much individual dependent. The workflow mandates a certain course of action, which is why you ought to invite your EHR people to the conversation up front and really make them a part of the solution.
That's right. That's right. We have an order set. We have an age-friendly ED order set that includes very fun things like make sure hearing aids are at bedside, make sure the lights are drawn when it's dark, like all those things. Yeah, I agree.
Exactly. And it's both. You need both. You need training, but you also need it hardwired. Evelyn, you get the last question of the session today. Over to you.
Yeah, sorry, I put it in the chat just in case, but when it comes to outpatient resources, and I think, having this follow up with these patients is great after an ER visit. But when it comes to resources, one thing that I'm noticing here in Los Angeles, in an area that's generally pretty affluent, there is such a backup with being able to connect our patients with the resources that they need, like the memory care program that we have here at UCLA, or patients are on waiting lists for adult daycare programs. And how are you navigating that in your areas?
Amy or Morgan, I'd love to hear, not that we have all the solutions, but thinking about it from a system standpoint. Amy, I'll go to you first and then Morgan second, arbitrarily.
Yeah, I think our first is going to be make sure we're actually using the resources that are available. But I do believe that it's a dichotomous system even here, where if you're really poor, we've got resources. We have a PACE program through our Medicaid. And if you're well off or upper middle class, a lot of times you're paying for resourcing. Sometimes we just need to connect them to those resources to do it. But I agree, there's still a gap in that kind of middle of the road population that tends to kind of get screwed always in our organization. Some of the counties have started to develop day programs at our senior centers. But I think right now the goal is make sure those sites are full so we can make requests of our county leaders, and we will be working with our county leaders to say we need more resourcing for our dementia patients.
I think it's a great answer, Amy. I did mention the Community Resource Finder. I shared a link to patient-facing resources, and that's one of them. But I do think it does take like a social worker or someone who's really fluent in what those resources are, not only through a list or an online link, but building some of those relationships. That's part of what you were just mentioning, Amy. So it's got to be dedicated within the team to really be fluent and build some of the relationships to make that work.
Awesome. What a wonderful conversation today. I know we may have slides at the end, Connor. If there's anything important, we can put it up. If not, we can let him go. I just want to say thank you. I mean, an hour isn't nearly enough time to solve dementia in acute care in the United States, but it's a great conversation. We are going to send out some of the resources and links from this. The Healthcare System Roundtable meets 3 times a year to try and tackle really important topics across systems that are working on making emergency care better for older adults. Please let us know any connections you want from this. And again, huge thanks to Amy, Nida, and Morgan for wonderful presentations today and catalyzing a great conversation. Happy Tuesday. I guess that's the one thing I was supposed to say. I didn't. Come back August 26th. Sorry. Great job, Connor. Thank you.
And we can add that into when we send out all the resources as well.
Awesome. Awesome.
I don't know, Heather and Connor, I was collecting all the links in the